Americans spend $4.9 trillion on healthcare every year. Not one of them can read their bill. Every hospital in the United States maintains a document called a chargemaster. It's a complete list of prices for every service the hospital provides. On paper, that sounds like a reasonable starting point. According to a 2015 health affairs study by Gerard Anderson, chargemaster prices are inflated far beyond the actual cost of services. They're the opening bid in a negotiation most patients never knew they were in. Insurance companies negotiate. They have legal teams, actuaries, and the leverage of millions of covered lives. The result is a much lower rate. Uninsured patients get billed the full chargemaster amount, which can run 2 to 3 times what any insurer actually pays. Opaque prices prevent patients from comparing, shopping, or pushing back. Confusion, in this system, isn't a bug. It's a feature. Every party that profits from the current arrangement has a direct financial reason to keep it exactly as it is. In 2021, federal regulators required hospitals to publish the prices they negotiate with insurers and what they charge cash-paying patients. A reasonable rule. Hospitals had time to prepare. The data existed. Hospitals often had the data and still didn't post prices in any format a patient could use. Some buried files in machine-readable formats requiring specialized software. Others omitted services entirely. Technically compliant, practically invisible. Congress also passed the No Surprises Act, a federal law designed to protect patients from unexpected medical bills, specifically the kind that arrive after an emergency, from providers the patient never chose and never agreed to pay. After a hospital visit, patients receive a document from their insurer called an Explanation of Benefits, an EOB. It details what the insurance covers. It's not a bill. It says so on the form. Patients pay it anyway because it looks exactly like a bill. The EOB arrives first, then the actual bill. They contain overlapping but not identical numbers. Reconciling them requires cross-referencing codes, dates, and negotiated rates. The process wasn't designed for clarity. It was designed by committee. Here's a misconception that costs patients real money. Many believe that once they've met their deductible, that annual threshold before insurance starts covering costs, they owe nothing more. Even after meeting a deductible, patients may still owe money through coinsurance, copays, or their plan's service tier. Different procedures trigger different rules. The deductible isn't the finish line. It's the point at which the finish line becomes visible. Hospitals often outsource billing and collections to revenue cycle management companies. Firms like Ensemble Health Partners or Optum 360, which the American Hospital Association estimates now handle billing for a majority of U.S. hospitals. The hospital sets the chargemaster price. The insurer negotiates it down. A separate company bills the patient for whatever remains. 3 organizations, 1 confused patient. The billing firm receives a code, not a description, a code. It translates that code into a dollar amount using the chargemaster. It sends a bill. At no point in this chain does anyone explain to the patient what they're actually paying for. Patients have the legal right to review their medical records, and recent federal rules mandate that providers must provide this information without charge. The information exists. Access to it is a separate transaction. Reviewing those records matters because billing errors are documented and frequent. Medical Billing Advocates of America estimates that up to 80% of medical bills contain at least one error: duplicate charges, services listed but not rendered, up-coded procedures. The chargemaster isn't a precise instrument, and starting prices have a way of surviving to the final invoice. So why does this persist? In 2023 congressional testimony, the American Hospital Association, CMS administrators, and patient advocacy groups all described the billing system as needlessly complex. The system continues anyway. The answer, as usual, is in the incentives. Insurers benefit from the chargemaster being high. Their value to employers and patients is the discount they negotiate. The bigger the starting number, the more impressive the reduction appears. Inflated prices make the insurer look essential. Hospitals benefit from high chargemaster prices because those prices anchor their reported charity care figures. Writing off $10,000 against a $4,000 actual cost produces a favorable community benefit report. The numbers are real. The relationship between them is flexible. The 2021 Price Transparency Rule was designed to interrupt this cycle. If patients could compare prices, competition would follow. Except patients rarely compare prices. According to HCUP data, about 14% of emergency department visits result in hospital admission, visits where price shopping is impossible. For elective procedures, a knee replacement, an MRI, price shopping is theoretically possible. The data is required to exist. But when hospitals bury it in machine-readable files requiring specialized software, the transparency is technical, not practical, a distinction the system finds very comfortable. For uninsured patients, the system is at its most direct. No negotiated rate, no insurer absorbing a portion. The full chargemaster price, which doesn't reflect actual cost, lands on a single individual. This is the system working as designed. The No Surprises Act provides real protection against one specific scenario: out-of-network providers billing patients after emergencies. It doesn't rationalize chargemaster prices. It doesn't simplify the EOB. It patches one leak in a system with several others. Patients can dispute bills. They can request itemized statements, cross-reference their EOB, and challenge charges. The process requires time, documentation, and persistence. The system isn't designed to make this easy. Most patients pay rather than audit. Scale this across a $4.3 trillion annual healthcare system, and the math becomes significant. Small billing errors multiplied across millions of patients. Chargemaster prices that never rationalize. Uninsured patients absorbing costs the system never intended them to understand. The system isn't irrational. A 2021 Rand Corporation study found that hospitals billed commercial insurers 254% of what Medicare pays for the same services. Insurers need the chargemaster high. Hospitals need it flexible. Billing firms need the process complex enough to require their services. Patient confusion isn't a side effect. It's what makes the math work. The chargemaster was originally an internal accounting tool, not a patient-facing price list. Health economist Uwe Reinhardt documented this in his widely cited 2006 Health Affairs essay, The Pricing of U.S. Hospital Services, tracing how it became the anchor for the entire billing ecosystem through institutional inertia. Nobody designed this outcome. Nobody has a strong incentive to redesign it. There are concrete steps available. Request an itemized bill, not a summary. Cross-reference it against your explanation of benefits. Ask the hospital's billing department about financial assistance programs. These aren't secrets. They're just not advertised. Nonprofit hospitals are required under IRS Section 501R to maintain written financial assistance policies as a condition of their tax-exempt status. These programs exist. Eligibility thresholds vary. The application process is rarely explained at the point of discharge. Each legislative attempt to add transparency has added another document to the stack: the EOB, the itemized bill, the chargemaster file, the No Surprises Act notice. The system now produces more paper explaining itself than ever before and remains equally opaque. In 2013, Time magazine's Stephen Brill documented a patient billed $7 for a single Band-Aid at a Texas hospital. The chargemaster listed it as a wound care kit. The actual supply cost was under $1. That gap between what something costs and what a bill claims is the entire system in miniature. When the next bill arrives, Request the itemized version, compare it to your EOB, and ask about financial assistance before paying. The system isn't designed for you to do this. That's precisely why you should. This audit is complete. The findings, as always, may be ignored.